Good morning. My name is Anita Day, my pronouns are she, her, and I'm Chair of East and North Herts Teaching NHS Trust. Today it is 14th of May 2025 and this is a meeting of our Trust Board in public. I'd like to welcome members of the board and those who are joining us online via YouTube. I'd also like to welcome, particularly this morning, we've got Paula Statham, who's going to be observing our board this morning, and we are expecting a couple of other observers and guests later on, but they're not here yet. I have, before I get into apologies, declarations of interest. I think everyone has seen our agenda for today. Would anyone have an agenda this morning? No, thank you very much. Obviously, our general declarations are on the website as always. In terms of apologies for absence, I have received apologies from Stuart Dalton, one of our NEDs. We were going to move to the patient story. Are we ready to? Do we know? Okay. If not, we'll move on with the agenda and pick it up when we can. But yes, if somebody could check if our guests have arrived, that would be brilliant. Let's move on then to the minutes. We could check whether there are any amendments that need to be made. Does anyone have any concerns or any corrections to those minutes? No? Okay, so we're happy to take those as a true record. I don't know, Debbie, are you able to talk us through it? Or
I am, yes, Chair.
Thank you, Debbie.
Thank you. So the first three actions are for July, so we'll leave those. The fourth one, 25/011, is completed. If everybody's okay, that can go. The May FPPC, the Finance, Performance and Planning Committee, so that can stay on and will come off of the July one. And then the Interim Chief People Officer was going to speak to 25/019. I don't know if she wants to speak to that now.
Yes, Madam Chair. We did discuss this at the People Committee, and there's a wider review of all the voluntary roles that we have to look at how we bring a business case together to support that more formally in the organisation. And we amended this date.
The 25/033 as well, that is included on the agenda, that's an agenda item. And the last one, Chair, is 25/035, which the Medical Director also wants to speak to.
That's great. Justin.
Thank you. Hopefully people have seen the slides. If you've seen the slides, what we'll see is that I've gone back to 2023 to May to try and answer the question, and slide 3 in the pack is a run rate showing what our non-elective length of stay is going back 2 years. The slide that follows that then compares us to other trusts, and as you can see, we sit fairly close to the mean level and slightly below it for other trusts. When we compare ourselves to organisations with patients with a similar demographic, actually we compare really favourably. There are 2 graphs in the pack on how we measure non-elective length of stay, looking both at point of prevalence stay by clinical service, and there are a couple of services that are outliers. I've looked in a bit more detail at those. The changes in medicine are around the change in bed management. The changes in obstetrics are actually around length of stay for transitional care for babies on the postnatal ward. Point that I put this pack together, we didn't have the IPR data for this month, but in fact the non-elective length of stay is not adequate.
Great, thank you to say that as regular viewers will see, I sort of sound like a television now, right. As regular viewers will know that we like each of our boards to hear from sometimes our staff, but often our patients. And we're delighted that we've been joined this morning by one of our patients. But I'll let Teresa do the introductions. Teresa.
Thank you, Chair. We're very privileged to have you here, Mary, so thank you for joining us. Mary's going to tell her story of all ages, and me as well to listen to some of the challenges that women have accessing complex services. But without further ado, if I can, Chair, hand over to you.
Wow, that's straight in, isn't it?
Sorry about that. I mean, if you need a few.
I had to get a taxi, so I was like, so it's weird to see you two are not about to go into surgery.
That's right.
I don't know who else was there, I can't remember. I have made some notes because at the moment I have two children, one doing SATs and one doing GCSEs, so my brain is a little bit frazzled and I didn't want to forget anything. So yeah, I'm Mary Kate. You can call me Mary. I was diagnosed in 2021. So quite late, considering I'm now 36. I've got two children. One of them is 15, one of them is 11. It obviously didn't affect my ability to have the children. I don't think my body would do it now, because everything seems to be much, much worse than it was before. I always struggled with periods. Period pain, heavy bleeding, but I didn't know what was normal. So I thought everybody else, bearing in mind I've got 4 sisters, I thought everyone else was dealing with that, and I used to look at my sister and think, this is information overload. How is she using these tiny little tampons? And I'm going through all these pads and I'm spending all this extra pocket money on what I should be spending on fun stuff. I'm spending on pads because I'm too embarrassed to go to my mum and go, there's just so much of it, why can I not go back and everybody else can? We didn't talk about it, so when I was at school, it just wasn't mentioned how much you're meant to lose. I don't know if it is now. I did try to ask my teenage son, but he wasn't really good at that conversation. So fine. But do they actually get told what is normal and what's not? Do you know how much you're meant to lose? Because I was losing chunks and it's tablespoons. I had no idea. So I used to go to school, my mum would give me a note. This is one thing that sticks in my brain. She'd give me a note for PE because I couldn't do PE because I was like hemorrhaging. But the PE teacher said to me, you have to do PE. It's good for you. Exercise is good. There's the spare clothes. Would anyone like to guess what happened to those spare clothes? I bled all over them. And I had to take them home in my bag, embarrassed, and tell my mum what had happened. I'm 36 now, it's been over 20 years, can I go to the toilet? And the teacher said, no, you've already been. I said, just let her go to the toilet, you don't know what's going on. I thought I probably shouldn't get involved, but I had to. The 16-year-old inside me was like, just let her go to the toilet, you don't know what's going on. So I thought what I was having was normal growing up. It really wasn't, it really affected my mental health. It stopped me from doing certain things because I would avoid going to places, I would avoid going out with people because I'd be embarrassed. It would also affect what I would wear. So I would wear loose things and try and cover it. And the idea that people would just wear white jeans was, how are you going to cope with that? So yeah, basically just really, really struggled. But after that is when the endometriosis went, I'm here now. And it was horrific. The bleeding got worse, the pain got worse. Going to the toilet was suddenly the dots that wasn't okay. I thought maybe after you've had a cesarean, the dots that wasn't okay. I thought maybe after you've had a cesarean, everything gets worse. And I was too embarrassed, which sounds ridiculous, but I was too embarrassed to mention it to anybody. I've also got 2 autistic children, so my life is very much making sure that they're okay. And it wasn't until during lovely COVID times, our landlord, because we were privately renting, decided to sell. And he didn't give us long to get out. So my mum said, come live with us. And then when I was back at home with my mum, she looked at me and she was like, what is wrong with you? I was like, this is just what happens every month. And she said, that's not normal. So off I went to the GP. I had a blood test, raised CA125, I put it down, so here somewhere. Got sent off for a scan, and I was so lucky in that scan that it was done by a gynaecologist. And she saw endometriosis and she bypassed out when she was doing the scan. And she said, this is really bad, let's just do the rest in the theatre. So I was like, oh my God, I'm having an operation, I can't have an operation, I'm a wimp. But 10 days later, I was in that operation. It all happened so quickly. In that operation is where
you might think my life got better after that, but it didn't. I was essentially disabled after that operation because he should have opened me up a month, not doing that, and held his hands up and said, I'm not the right person for this job, and sent me off to somebody else. But instead, he gave it a go, and he caused more damage. So then it was use my left leg. I don't know what he did with that heat thing when he was burning. He must have caused damage. Oh, okay, I'll just leave it as that then. I'll just live my... And I said, what do you mean? And I just left that appointment thinking, am I going mad or what? And then I started my fight, idea what endometriosis even was. So I researched it, learned about it myself, had to fight for myself to get referred to Dr. Lim because I met that criteria. And then, Dr. Lim kind of changed my life, made it so that I could go to the toilet for a number two without feeling like someone was trying to kill me. I'm one of those things that happens. The problem was, I've written this down. Well, I should have said was, which is not. I didn't have that before, which sounds ridiculous, but a doctor hadn't actually gone, this is endometriosis. Sorry, I'm waffling, aren't I?
No. You didn't. Not at all.
So I was kept in because I woke up from this operation, I've looked down and there's blood. So I rang the bell and was like, I don't think that's meant to be there. They pressed on it and it stopped bleeding, so it's fine, but I was in so much pain. I went to A&E. No, I didn't. I stayed in, until the 13th of August. Then when I got home, I went back to Lister A&E on the 16th of August, 6 days post my stomach. I don't know if you can see it. But for 11 hours I sat there. Eventually they got me in bed, told me that I might have to have the hematoma drained. But I ended up discharging myself, which I know is naughty. But I called my husband and I said, you need to get me out of this hospital right now. And I pulled the camera out and I left. And they were saying to my husband, please try and convince her to stay. And he said, no, she's been in hospital her fair. And I am really grateful that he had my back there and didn't try and make me stay because I wasn't getting given any painkillers. I was told that it was just endometriosis, like it's just, one of those things. But I have put a message here because I had that surgery with Dr. Lim. There was no way to get back in. I was just on my own. I had nothing. So I've got this complication. Where do I go? I've been to A&E, I've been to Hemel Urgent Care, I've been to Watford Hospital, I've been kept in there. I didn't know what to do anymore. And I was still in absolute agony with that massive bruise into him, which is not something that I can afford to do, but I did because, I was in so much pain I didn't know what to do. And bless him, his secretary got back to me and said, he's going to see you urgently on the NHS. That's fine, come in. And I did, and that was that. And when I saw him, he hadn't been told that there was a hematoma. He was completely shocked. So I didn't see him until 1st of September. My surgery was on the 10th of August, so no one had got a message back to him. There was no endometriosis nurse helping me. There was just, here you go, you've had this operation, see you later. Which wasn't okay. So on the ward, which looking back, I should have put a complaint in. I spoke to you before the operation, the last one, and I should have put a complaint in. I would, because I feel it. Give me any painkillers, and just told me to keep changing the dressings and pressing on it, and it'll be fine. And he was really, really good. Bless his heart, hematoma is one of those things that happens. That we're all human. It happens. There's no bad feelings with him at all. He looked so shocked that I hadn't been sent back to him. How many other people were struggling like that and not been sent back? And just won't speak up for themselves because I'm in now. Follow up with a member of Dr. Lim's team who tried to discharge me after I've just been diagnosed with stage 4 endometriosis and meant to be kept on that list for several years. So I said no. Had a big complaint about that. Then I joined the Regal study. The chemical menopause was fun. Really, really looking forward to doing the actual menopause now. I had all of the side effects of that, but it really, really affected my left leg. And whenever they gave me that injection, just on the left side, because they alternated, the left side, I couldn't use my leg for about a week. And I can't live like that. So I ended up coming off it. I give it a good 6 months, and then I ended up they were horrific, to be honest. I was like falling to the floor. And I've gone back on the list for the 3rd surgery. I've had the surgery, and now I can go to the toilet. So, yeah. But I know that that's going to be my life. It's like a vicious cycle. But if we just keep getting discharged, that's a really big weight to get back in for just one appointment when we actually know what we need. Sorry, I feel like I'm really rambling.
Thank you so much. Can I just say, I'm really, really sorry about all the time.
I've got one more thing I need to say, and I've printed it out. So this operation I had, I don't know if you've looked at the notes from it or anything, but it was like stage 4 again, like I've got, a lot going on. So this was my discharge summary, and I haven't complained about this. Diagnosis, no problem recorded for this patient. Past medical history, no problem recorded. Treatment, no, not recorded. Okay? So, what was the last bit here? Procedures, no procedure recorded for this patient. I've just had major surgery, well, what I say is major surgery, like it was on my bowel, all of that stuff. Procedure notes, not recorded. Now, I'm in a different NHS trust, it's 2025. You guys don't talk to each other. Okay, this is bonkers. Because I go to Watford and I say, I've got this post-op complication. Well, where's your discharge summary? What did you have? Nothing. It doesn't make sense, does it?
No, thank you. As I say, I'm really sorry about all the things where we as a trust felt, but obviously it's a very complex story. It's involved parties as well.
Yeah.
Let me open it up for questions and comments. Teresa.
I just want to thank you, really, Kate, for being very brave and telling your story in its entirety, and it's an experience that none of us would want you to have gone through. And I guess we've had some really difficult patient stories at board, and we've leaned into the solutions. And
That's exciting.
that's it. One of the things that me and Kate and I talked about is how do we build a wraparound improvement process that really addresses this specific need for women who are very vulnerable. So I'm really excited about a piece of work I'm hoping maybe Kate can sort of join us with in terms of are we doing the right things, which is making accessible to patients with endometriosis a helpline. So if you've had surgery or symptoms, you'll be able to call through, speak to a clinical nurse specialist, and they will field the right results, be it diagnostics, be it a medical appointment, and they'll be your kind of guardian. Now, we've done this in learning disabilities. Our previous patient story has been to board, and I'm hoping that in 6 months' time, Mary Kate will come back and say, I can see some improvements. I think the joined up working is very important, and we know that Mary Kate, you're one of a group of women who are talking across Hertfordshire
I've got some notes actually.
And you represent their voice as well. So there is a bigger piece of work that we need to do systems-wise. But from an improvement perspective, I think the accessibility, not having to wait an ED, having that direct link is something that I'll take forward personally.
Thank you very much, Teresa. Yes, absolutely echo. We are really grateful. It's not easy listening for us, but it's much worse for you experiencing it and living it. And anything you can, by sharing, you help us to put in place the sorts of changes that Teresa's talking about. We are really committed.
Yeah, I think my main thing is having a daughter who is 11. I want it better for her generation. Because she's terrified watching me, bless her heart.
Yeah, of course.
I can I have to say that there are many women who maybe won't have suffered as much as you have, but have absolutely experienced evidence that I have myself, and I can absolutely sympathise with lots of things you say. I've certainly been through that. I know Adam, but I'm only, is there any other questions or comments from Jill?
I mean, thank you so much, because this is exactly what we need here. We want things to be better, and to have the issues outlined so clearly for yourself is what we need. So thank you. My question is actually to Teresa, and I'm just wondering, there are a number of issues that Mary has raised that are in our sites, actually, if we think of discharge letters and things, but something new for me, which is my question, is had the specialism specifically raised in any way to the executive business planning discussions where the priority and need for having a specialist nurse? Because that to me is the linchpin of the gap that enabled everything to fall through. Had that been raised by the specialism before?
So there certainly has been a focus around how do we treat, and this is where there'll be some interesting views, how do we make sure that there's accessibility for gynecological women 24/7, actually 7 days a week. Now, Mary Kate would say to me, that's fine, but a general gynecology CNS may not be able to deal with the specifics around an endometriosis patient. But I believe that we can train our CNSs in gynecology to do that. And I think the service themselves have raised, why don't we have a much more 7-day working environment, specifically around the areas that you've pointed out, the sort of coordination, particularly around discharge practices, so you don't feel that you're completely on your own and isolated. So Mr. Lynn and the team have raised it, and we're going to work together as one group, one team with our patients to find a solution.
Any other questions or comments? No?
Different circumstances, but you were, even at that point, pre-surgeon, you were very articulate and not just telling your story, but speaking on behalf of.
Nervous talking because I was more nervous about it.
Well, Minister Baroness Merrin came to visit, and she's really on a mission around women's health and endometriosis, and really celebrated. Actually, we have had is that we were able to do a number of things because of the expertise, but the commissioning rules didn't allow it, so there were patients having to go off to other centres, and yet there was the capability, and hopefully some of that is changing. I guess my question is one for Mark, really, because recognising there are some errors we made within this organisation which we are entirely accountable for, you also describe some real challenges at others, and a particular theme of, if you're bouncing between different organisations, why can't everyone see your information? So Mark, thinking about the shared care record that is adopted across the system, the kind of information that Mary was highlighting, is that something that, whether she went to Watford or Hemel Hempstead, or whether a patient who had been treated there came to us, our clinicians should be able to see sufficient information to make that experience much better, and therefore it implies they weren't looking? Or is it that the shared care record is too limited in the kind of information available to people?
So anything that we create digitally, whether that's East and North Herts or West Herts, will be fed into the shared care record. So theoretically, all of that information should be available, but not necessarily in the same field or in the same format. So West Herts discharge letters and documentation will look very much different to ours. So all that's accessible, but in theory,
if we flip it on its head, if there'd been surgery at Watford, summary in a different format, but in the system, and be able to get that information, recognising that it was a poor discharge summary that didn't get information, but if it had.
So that letter would go, and that same letter would get fed into the Herts and West Essex shared care record as well.
Every time I've presented myself at A&E, they can't connect the dots. I've had some horrific times at A&E. The last time I was there, it was actually a woman. Now, women, I hate to say it, but are often the worst at understanding endometriosis. And I had this healthcare assistant who, someone else said, oh, why is she here? Bearing in mind women's problems. And you just think, you're a woman. Like, you're working in the health system, you know that there's these conditions. But yeah, every time I have been to A&E, they have said that they can't do that. I think even Dr. Lim before, when I've had an MRI somewhere else, he was like, I can't access it.
Yeah, we need to look into that, because it absolutely should be something that we can do. Justin, you wanted to come in?
Both true. So it is possible to get into documentation that is held on the shared care record, but it's not commonly done because quite a lot of our staff still don't understand how to use the system to do that. So there's a piece of work that we need to do to help people to use the system properly. It's not entirely straightforward, but there is a way of getting it from the ED record into the shared care record. and I have done some work around communicating that to different teams, but we need to do some more work on it.
Does it mean not? They don't have time to work all this out.
So-
You need to be.
So you can get to it. It's not the most user friendly when you get to it, and it's a little bit tricky if you're not used to doing it how you get there. So we need to make it easier to do the right thing, and that will make life for patients better, and it will make life for doctors and nurses better. But I'm
But if
also
it's
sorry about
hard-
the stuff that's gone wrong.
Thank you. If it's hard though, I'd rather like Dr. Liv, instead of fussing trying to find my thing, he moved on to the next patient because that lady's struggling too. It needs to be simple, doesn't it?
Really, really grateful that you came in. This was not an easy story to tell. Talking about these things in front of a group of strangers. I know you've met Adam and me, but you won't met all of us, and we really do appreciate it. And it's important because when we get things wrong, or when there are things like you were saying about is it too difficult for people to access the shared care record, those are things that we're going to take forward as actions that we will work on. So we are really grateful for your time today. I'm sorry that and I think we won't forget what you told us. And as I say, some of us will have experienced some of that as well. So we are. I am pleased that you appear to be in a better place now than you were, well, certainly when Adam and I met you last time. I'm glad of that. But it sounds like it's going to be a bit of a journey, and wish you all the best. But really appreciate your taking the time to come in today.
I'll get a retask and finish strips together. Thank you.
That'd be brilliant.
Thank you.
Thank you, Mary Jane. Really appreciate it. Thank you. That's lovely. Thank you. And that's why we have patients' needs, because we need to hear when things aren't working well, and that's how we can make it get better. So that's really good. During that time, we would like to welcome our board today. She will be joining us as our Chief People Officer on the 1st of July, I believe. 7th of July. Certainly it's lovely to have you join us today. Going back then, our agenda, we got a little bit higgledy-piggledy, but I think we can get back on track. The one thing that we do have is we have actually received a public question this month, or last couple of months, which is in your packs services. And I believe Therese or Justin, one of you could give a response. Thank you.
Yes, absolutely. So thank you, Chair. It's a very good question that we've had from Mr. Porter. And I'd like to start by apologising for the very long wait that our service users, both children and adults, with services approximately 2 years ago in England, and that did result in some services like ours being re-reviewed for clinical standards, SOPs, training, and also the capability of the individuals doing the test. And what that meant for us was that some of our services, in fact nearly all of our paediatric services, were closed. But what didn't happen was the referrals were not stopped. So the referrals kept coming in even though the services were closed. And the governance around this has been that on a weekly basis we've been meeting the regional team, the national team, and indeed the third sector charity community to help support our community around audiology practices across all the areas. We have a best-in-class appointment in our lead audiologist, who's not just working through our waiting list, but is also advising other centres. And we are working sequentially through our waiting list. And I'm really proud of the work that we've done to date. We've engaged the independent sector, and we're using them and have continued to use them, so I think that's making a great difference. But where we want to get to is to be able to come back and report to the board, to be able to explain that we are making progress on those lists, in Safety Committee and also at execs. And yes, we are taking it seriously, and that's why it's rated as 20 on our corporate restriction. I'm happy to pick up on the question.
Thank you very much, Teresa. Any questions or comments on that point? Adam?
Just to add one brief bit to the context for Teresa, when she was saying that although we paused the service, we didn't stop referrals. To close a service to referrals is a commissioning decision. And I contacted the ICB as our commissioners to request that, but for understandable reasons, they local services, and then by doing that, we would be artificially making their waits even longer. So the view was that we needed to keep taking the referrals until it got to the point that when it became a problem. So that was the context of why we didn't close the service to referrals at that time.
Yeah, thank you, that's helpful. Any other questions or comments? Teacher
Do we have any view as to when these witnesses will be sort of coming closer to the meeting?
That's a great question. So it's going to get the waiting list back to absolutely right place. It's going to take at least 2 years probably. If we can do it early mutually, these are really significantly large numbers that we would have to make sure that Cambridge, HCT and other organisations can help. And mutually to date has not been terribly successful for us. Very small numbers we've managed to send out with very variable results. So vulnerable children, vulnerable adults, great communications with GPs to make sure that everybody's informed and aware. But unless we get some big package mutual aid, it's going to take at least 2 years to get this last one.
Thank you. Lucy.
Perhaps give a little bit of an update from a regional perspective in relation to the regional diagnostics leadership team request across the whole region for mutual aid, not only to our trust but to 2 others as well. It is essentially for all trusts that provide paediatric audiology in the East of England to pause the majority of any of their non-urgent services in order to support ourselves and the other 2 trusts that have the longer waiting time, so at a regional level. It's quite difficult to organise on a day-to-day basis, but that request was made about a week ago.
Moving on then, the next on the agenda is the Chair's report. There is no paper, just a couple of comments from me. As I think we are all aware, and in fact I mentioned it at the top of this meeting, the Department of Health and Social Care have now approved our application to become a teaching hospital. We therefore do have the word teaching now in our name. We're in the process of changing all the signage and our sort of various teams backgrounds, so various things that we have to do. We're in the process of doing that. It will take a little while, I guess, for it to come through everything. But we are indeed East and North Herts Teaching Hospital. Teaching NHS Trust is our full name. That was from the 1st of April. As a consequence of that, we have initiated the reciprocal arrangement we have with the University of Hertfordshire, such that Professor Zoe Aslanpour is now a NED a non-executive director on this board, and Dr. Justin Daniels, our medical director, has joined the board of the University of Hertfordshire as well, and that's to really embed and strengthen those really critical links. The university already provides students, and we work with them on nursing and midwifery and paramedicine. That medicine is the missing piece, and it is a really important piece, and we're really looking forward to the beginning of the medical school in 27, I think. 26, thank you. Lovely, it keeps moving. The final thing, just to mention, as I say, I think I'd already mentioned Penny St Martin has joined us, or will be joining us as Chief People Officer on the 1st of July. She is with us today, but we look forward to working with going forward. I'm going to leave it there and hand over to Adam.
Thank you very much, Chair. So my paper changed the format going forward to really move away from our 4 themes to provide a more open presentation, but particularly with the focus at the moment on some of the national and regional changes that are impacting. People will be aware that there was an announcement that the NHS England is to merge into the Department of Health and Social Care, and that will come with a resultant 50% headcount reduction in those organisations. And then alongside that, another announcement came that in a similar way, all ICBs were to reduce their running cost by about 50%. That's now been nuanced slightly, that every ICB needs to be running at a cost of £18.76 per head of population in terms of its cost. So those that were already more efficient are getting a lesser challenge. Conversations are taking place at the moment about what that looks like, but it's changing almost on a daily basis. We're expecting very strongly that the way in which some of that will be done will be they'll be in. And so Hertfordshire and West Essex ICB is unlikely to remain in that format. And there's also a significant change to the role of ICBs. And again, the detail will be coming through very specifically and in the granular level. But the headlines are that ICBs will move to become more strategic commissioners. So there'll be focus on population health, inequalities, looking at the population need. Will move to a regional level, others will move down to providers, and providers are going to be asked to take on a greater responsibility. And one of the vehicles through which that is going to happen will be the creation of or strengthening of place-based arrangements. So as board members will be aware, we're part of the Eastern North Herts Health and Care Partnership. But we received a letter allowing us to run as a subcommittee of their board, are wanting us to take on a host provider model where Eastern North Herts Teaching Trust will become the host provider for local healthcare services, with increasing amounts of delegation for those services to our control or accountability. Initially that will predominantly be in adult community services, but over time partnership with our neighbours in the oversight of that. But we'll bring some formal documentation through to a subsequent board meeting where we really need to look at the governance, because what happens is, as well as responsibility, risk will move from the ICB into our organisation, and we need to be content that the governance arrangements in place are robust, manage risk in an appropriate way, but also, on a positive, really give that opportunity for greater and greater joined up working. And as we've heard already, our objective of seamless services and how do we work with partners to make sure people don't fall through gaps, and it's very smooth. We have, and people will see on the board, assurance framework later, included that sense of change as a real risk for us, because in any organisation having to reduce by 50%, there will be lots of focus on what that means for staff, what the actual execution of those changes are, changes in role, and at a time of uncertainty. And the risk is people are distracted from the task at hand. So we've identified that as a risk that we need to mitigate. Teaching hospital has already been mentioned by Teresa, but alongside that, we received a letter from the regional team very recently as part of the national oversight framework, moving us up from a segment 3 to a segment 2. There are 4 segments, so we've now moved to kind of better than average, if you want to describe it that way. And there's a letter attached to the paper where the region highlights the reasons for that. And I think often at the board, and as today we've demonstrated, we don't want to shy away from the areas we need to improve, but maybe sometimes don't recognise enough publicly the areas we're performing strongly on. And so some of the items highlighted, we are the best performing trust in the region on our elective waiting times. We're in the top 10% on our cancer performance. We're one of the very few NHS trusts that was able to deliver a financial break even or a small surplus. And has been highlighted here, and I think the first time we're really formally recognising it is we were the 4th most improved trust in the country on our staff survey results. So some real positives. But again, really then looking at the areas where we need to improve, and we've already heard about a long wait in ED and what that can mean. So although our performance against the national 4-hour standard has been improving, 12 hours remains an area that we really want to eradicate. Anyone waiting that long, there are different solutions to that problem because they are generally not within ED, they're deeper into the hospital and discharging, for example, but that's an area of real focus that we'll be putting into this year. Another big change for the organisation from the 1st of April, we became a smoke-free trust. We joined, many others have already taken that step, but we know that smoking remains really important as a healthcare provider when we know that information that we signal very strongly. So lots of work has been led by Justin in that, because discussions around including vaping or not vaping, looking at the government's legislation that's being proposed around probably making it a legal issue, not just something that we mandate as a trust. So that's something we will continue to kind of police and monitor and provide lots of alternatives for people to smoking, because we know it can be a genuine life changer. And then I've just included onto people here as well as Penny's imminent arrival, just highlighting some of the national awards that members of staff have received. We've heard kind of plaudits around Mr. Lim already in this meeting, but a number of our staff have received national recognition, and Teresa and I were delighted to accompany some of our midwifery team to the Mum Awards in the House of Westminster, and it was a real joy to hear those teams, after what's been a challenging couple of years for them, to really turn that service round to get national recognition in that setting. So I'll stop at that point. Happy to take any questions.
Thank you. Any questions or comments for Adam, please? No, it looks like not. So thank you. Oh, sorry, I apologise. And Kevin, sorry.
That's right. So firstly, I'm pleased because I want to ask questions about the government's arrangements given the change in the structure of the national level. Also, the fact that we've got something in place is obviously very encouraging. When we look at the impact on our host provider status, and host provider for the region, do we have any sort of understanding what that would mean in terms of our resources? Because obviously that's one of the key things that we need to rely on. And then secondly, are there any case studies of other trusts that have sort of done this? Is there some sort of people which can see?
Yeah, so some really good points, and in part this is all emerging.
Mm-hmm.
The best case study we have is our neighbours in South and West Hertfordshire. So the plan had been until very recently that both South and West Hertfordshire were going to move into a lead provider, host provider model, moving to a lead provider, and I'll touch very briefly in a moment on the difference. And West Essex were also going to follow a similar approach. We had decided in place jointly with Hertfordshire Community Trust that we would kind of jointly lead our place, and that we would, rather than set up separately, would just remain a subcommittee to the ICB. The ICB made that change in decision that they wanted us to adopt the same, in part because of the uncertainty around the ICB, and if there's no ICB in the same format, how can you have a subcommittee? So we are now having to move at pace on this, but a lot of work has been done, particularly in South and West Hertfordshire, to really work through the model, lots of legal advice, governance advice. So our approach will be to lift and shift that model as a starting point. We'll take our own legal advice to make sure that we, as an organisation, can rely on that. But then probably that will be the model from the 1st of July. But then there will be phase 2 when we really want to iterate and get into some of the nitty gritty, because on headlines these things seem quite easy. It's when you get into the detail around conflict of interest agreements and other things like this that we need to make sure it's very robust. I guess the question on resources is that as part of the signalling from NHS England, what they believe that if financial resources have been muddied over the years, and there has been a number of organisations that have received deficit support because of their underlying financials. We've not been the beneficiaries of that because of the good financial housekeeping that there's been. I think there's going to be a resetting of that to really put the problems where the problems are. But also, NHS England are very keen to make sure that populations are funded appropriately for issues of deprivation and others. So over this next year, NHS England have committed to a new financial framework, so we'll have to be clear what that looks like. But in terms of the actual place, I think the resource issue becomes, over time, particularly as you move from a host, which in simplest terms, we will take a fair bit of accountability for the performance of healthcare, but we won't be contracting directly. That will remain with the ICB with other providers. As it moves to a lead provider model, it's far more likely that the ICB would commission from us and we would then subcontract to other providers. So each of those stages, we as a board will need to be clear on the very point you ask around what does that mean in terms of resources. But I think the underlying principle is that how do we best spend the Hertfordshire pound for the population in a way that avoids duplication, really focuses on improving the health of the population, and a belief that if we can if the NHS can encourage providers to take more and more responsibility for that, rather than managing the activity they do, we'll get a better overall delivery.
Thank you. Kevin?
I was just highlighting the tissue.
Oh, sorry,
Sorry,
I hadn't noticed your thing. I apologise. Okay. Any other questions or comments for Adam? No, great. As Adam said, these are very exciting times. So there's a lot of work to be done, but if it actually means that we are able to make those decisions for the citizens of our part of Hertfordshire, I think that will be and help to lead some of that. I think it will be very, very positive. Right then, moving on. The next thing we have is a strategic goals update in the agenda. Now this is an item which is for assurance purposes and has currently been rated by the executive team as partial assurance. So one of the questions that I will be asking at the end is, are we comfortable with that rating? Do we, Kevin, to summarise today?
Thank you, Lisa. So yeah, clearly the report outlines two key things. Partly it's around our evolving approach to our strategic goal process that we've been working on with our improvement partner over the last 18 months, 2 years. But the main body of the report is a summative selection of the types of improvement activity that's been undertaken by our various teams across 2024-25 in pursuit of our trust vision. There's a lot of detail there and richness that's deliberately done, so I apologise for that. I'll take it as read, but I think it's probably kind of key for sort of observations that I just want to kind of bring to the attention of the board. I think on the first point, probably just in terms of context, it's about our cascade process. I think we are a new and forming board still with a turnover that we've reported in previous months with several new people that have arrived. And so we haven't had a board opportunity to go into the sort of background to what's been going on over the last sort of 12 months or so. But we have deliberately moved away from the historical kind of top-down annual approach involving targeted initiatives that were done previously, where very much the feedback from the organisation was they didn't really understand what their role was to play, and within those objectives they didn't really understand how they could contribute towards. So we have deliberately in the last sort of 18 months moved away from that to broader, more ambitious multi-year goals, where we're really trying to frame things so that regardless of where you work, who you are, or whatever level or whatever staff group, you can really understand what your role is to contribute towards that direction of travel. And it's really that kind of focus that, we set the strategic goals, that is the direction of travel for the organisation. As soon as it moves out of that and into the divisions and the corporate areas and beneath, that's when it turns into action. The activity that teams are going to do towards those goals, and more importantly, what are the metrics that are agreed that will evaluate progress in achieving this. Different examples, some of which focus on smaller scale incremental continuous improvement. Teams like T&O, trauma and orthopaedics in the example, or musculoskeletal services, or the pharmacy, using that plan, do, study, act. One small change at a time is building up to a bigger picture of incremental improvement and the aggregated improvement overall. But then the examples led by digital and Mark's team around the real radical transformation that we're undertaking within contact centre and outpatient services that we've also previously talked at board. As we roll out our different training office for the Eastern North Wales production system, the emphasis will be both on looking to expand the coverage of incremental continuous improvement bottom-up approaches, and then the larger scale breakthrough improvement with teams that is cross-divisional, cross-functional at the same time. I won't dwell on the third point too much, and it's, I'd reframe it because we've had some really powerful patient story against women with Mary Kate, and we've had the audiology question. We know that we have challenges. We know that we've got areas of performance where we see green shoots that we want to do more. But I'd also just sort of recognise, as Adam always kind of puts forward in his reports, that there's lots of areas where the teams, and again evidence in this report, have really delivered some fantastic achievements. And where we haven't got the performance where we need to, that forms the basis of the objectives across 25-26.
the only thing I probably add here, because I think Adam's covered most of it, is when it comes to productivity and efficiency, we continue to sort of report in the upper or top quartile performance at NHS in hospital across inpatients, outpatients and theatres, and at a recent national CEO call, it was reflected that the rate of productivity improvement at Eastern North Hearts is double the rate of the average across the east of England. And I think that is something that we just sometimes need to sort of pause and reflect and celebrate the great stuff that our teams are doing. Though obviously we can't stand still, and it's always about how we continue to build on those improvements. I think then, just in terms of the year ahead, 4 goals with the senior leadership team, so over 100 staff, to ensure that they still fit for purpose. We've done a bit of a horizon scan because there's a lot of changes that Adam's just alluded to there that have been going for some time around policy change and that. And we've made a bit of a catchable feedback exercise just to ensure were these still the right goals moving forward for the organisation. And for us, it made sense that very much they were still fit for purpose. But there's 2 key learning points for us. The first one was just again in terms of reframing, and we've gone one step further to simplify forward. The language is more simple, and again that's just so that it's really easy for teams everywhere to understand, well, what is my hook? How can I play a role in delivery towards that content? And the way it permeated down across into divisions, the variation there, I'd highlight cancer services who have got a really well established process for departmental objectives and metrics that demonstrate progress towards that, but that's there across some other areas. Put it into context last year, coming out of a large divisional operating model review, and then the timelines and delays during the summer months to just get the right people into the right place, then we can understand that perhaps that kind of affected aim and expectation for 25-26 that each corporate director and each service line has their own local SMART 8 annual objectives that align to the goals. So there's a clear activity plan of what it is they're going to do to deliver those objectives, and that there is clear metrics that they demonstrate to show performance and impact. These will be monitored through divisional boards, and then escalation on a quarterly basis through our divisional performance review meetings. Martin, our Deputy CEO, has kindly drafted a revised accountability framework that's out for consultation. We hope to have that signed off for the end of May, and that becomes the vehicle for how we manage all delivery aspects of performance, including the strategic objectives, as well as then having those divisional and service line objectives feed it up to the organisation. We will also undertake a review and map across from the strategic goals what are the key performance metrics from the IPR, the Integrated Performance Report, that we will use to guide and show the overall performance and trajectory of our progress during the course of the year. I'm mindful that this is as much about cultural change though as anything else. We've talked previously about the different offers within our Eastern North Wales Production System training. A big part of that is advanced daily management, which is how we coach and help people to make those day-to-day links between the work I need to do today versus the work I need to do today, tomorrow, next week for the strategic alignment. And that will be another part of focus for how we evolve and expand the work in the year to come. We've also designed and launched a Managers Toolkit in April, and that's helping facilitate managers and leaders with their local conversations, so how they engage and agree their local objectives with their teams. Very much the aim that they then need to be published in a highly visible place in the wards and departments. And then as leaders from board right down to middle and lower levels, it's about those curious conversations when we go out onto the campus and talk to people, asking about how things are going, what they're doing, and what the challenges that they have in that. I've already started planning for the strategic cascade for 26-27, which sounds like a long way away, but it's not. I think the 3 or 2 key things there will probably be how do we ensure that it aligns much more closely with our really well established touch points with board, so that there's space and time for us to get a coalesce around this work and very much agree any sort of changes or developments around strategic goals for the year ahead. I'll pause there and open to questions.
Thank you very much, Kevin. Questions on the calendar.
I'm just really interested in how we would take our patient's story earlier, which, for example, talked about some of the problems of joining up across the hospital. So, for example, we've got somebody coming into the emergency department with a particular issue, and they need help and support, but they can't seem to get through to another part of the hospital where perhaps they've been seen earlier. As we know, we've got lots of different complications that people can have when they come in. So how, through using this type of system, can we also begin to look at how we address elements of those, where it's not just down into a particular department, but it begins to go across?
So one of the, it's a really good question. One of the key things that I haven't mentioned in the report update, but we are very much working in the background across the corporate and the clinical divisions, are the value stream process, the value stream development, and that is getting into exactly the area that you described, where there are those cross-functional challenges and issues across different services and pathways. And what we are working up within each area, what are those priority areas that we can dedicate our resource, our pricing promotion office and other resource to really focus as part of this work. And what we're trying to do with that is ensure that we align that work and the prioritisation of those value streams into the splitting. That's where we agree prioritisation and oversee the ongoing delivery and implementation of that process. You know, previous boards, I probably talked about the rapid process improvement workshops with the programme of improvement that would encompass several of those events over the course of time, where you're working with those cross-functional teams, working on each aspect of the pathway that's creating challenges at the time. It was being identified through risks, incidents, patient stories, etc.
Richard.
Go ahead.
Kevin, you talked about cultural change, and I was just wondering, have you had to think about what the metrics are going to be and how we're going to measure that cultural change over the next 1 to 5 years?
So again, a really good question, and yes, there's been lots of conversations about that. I think there's some obviously straightforward ones that we feel at TGT that do strongly resonate, and that's about the STAR survey, and that's both in terms of some of the generic improvement that we've seen with those scores, the fourth most improved trust, for example. But when you look into some of the detail, some of the metrics, particularly around staff expressing that, you know, I have ideas for improvement and I am listened to, and those kind of elements, there are some very specific metrics that we want to build into that. Process, we undertook a transformation continuum where there were several themes around the key elements of organisational change and culture change, and I'm revisiting that at the moment, and we'll be doing a sort of health check assessment process at the end of July and the beginning of August through that. So I think I'm scheduled to bring the first cut of what that will look like to people at the Culture Committee in July. Thank you.
Thank you. Richard.
Thank you. Kevin, thanks a lot for this. I think it was really good, and I applaud the efforts to, let's say, improve our entire goal and objective setting process. I think it is one of the vital things to get right from my experience in organizations. You've said all the right things in terms of what needs to happen, but in reality this is a really difficult process which organizations go through multiple years of getting right and better over time. And the ultimate, I think, measure for success is that we achieve our goals, right, as an organization. So I've got two questions really. One is around not just be through the line organization. So think about how do we really check the quality of the objective setting process, right? And that's a question you can answer now, maybe later in one of our board meetings, but I think that's a key thing to do. And then how do you ensure effective performance management based on the objective setting process? And you talked about the accountability framework. I think that's a really good step in the right direction too. And my personal experiences in objective setting process, people when they talk about it, it seems like the obvious thing to do, right? But to create smart objectives that really, so people need to be really trained, supported, developed in order for them to do that well.
and you talk a little bit about it, that it's almost like, well, you know, they can do an e-learning type thing, and then they know it, but that's not for us coming to work. So I'm talking about the robustness of the process. What do we do to support our leaders in this process? What do we do to check the quality of the objective set of process?
So, I mean, they're all really good questions, and as you know yourself from previous conversations, some of those questions are things that we've pondered as a board, and there is work that is ongoing that will work towards that, like the accountability framework design. There is an element within the training programs that we are running like leaders, that is an intensified data leadership program, and actually a lot of the content of that program goes through exactly what we're describing here, and it goes into ensuring that we have better quality objectives. I think we're really right to look on it as a challenge and as an issue for us as an organisation, because one of the reflections would be from last year that almost in some areas the goals that are set that are quite broad and ambitious deliberately seems to get into were reframed in a similar way. And I think that's part of the cultural change that you're kind of reflecting, that is an ongoing piece of work. And there's no straightforward easy answer that I can give you to all of them, and I know you're not looking towards it, but I also take on board the comments to make sure that that's factored into subsequent conversations along with the other bits of work that we're doing.
Right, I'm conscious of time, so we do need to move on, but I've got one more question from Teresa.
I just think, Kevin, I'd be really keen to understand how you think the productive board visual system is going to work in relation to strategic priorities. Because I guess, you know, when I'm working clinically with my teams, it's can I see it, does it make a difference to patients, and does it impact how staff work? And I just wondered how that you could explain how that might work.
So, another really good question. Thank you, Teresa. So, a key element for me, my response will be around the elements of advanced training management, which is the infrastructure for improvement that we're putting into the walls. Many of those elements, as you go around the huddles, sometimes how we're using them currently to how we intend to use them, that's the part of the cultural change that we're working on through the leadership program, but we will be building on other training offers in course. Elements of that are things around the strategic alignment board, which is in a way the contrast to the production board, which tells you about what are the demands I've got today, what's my capacity, and most importantly, what are the visual management ways to describe when I'm not in the place that I need to be, and what are my controls and mitigations I can put in place to improve that situation. The strategic alignment board is going to focus on tomorrow, next week, next month. That's where that kind of information around the local objectives and the work behind it should start getting displayed along with the metrics. So there is that kind of daily reminder of the work I'm doing today and the work tomorrow. It's not as simple as that, as Richard has clearly identified, and it is just around working with leaders to work in different ways, because as an organisation, historically, you know, we are great at a crisis and we can manage those things really well. And this is true of many NHS organisations as today, and that's cultural change.
Right, thank you very much. I'd like to bring the discussion to a close. Thank you, Kevin, and thank you for the various questions. I come back to my first question that I posed. It has currently been assigned an assurance level of partial, but I was struck with it all, but I think there was a significant amount of progress there. So I was wondering myself as I was reading it whether an assurance level of reasonable might be more reasonable. But I'm very much interested in the views of the board. Are we comfortable with partial? Do we think it could go up one? Oh, well, no. I mean, if people are happy with partial,
partial.
We stick with partial. Okay, that's fine. Thank you very much. Right, moving on then. National Staff Survey results. Amanda.
There is the report in your pack, and we'll take those instead. There are some highlights I do want to focus on from the board though, and Kevin touched on that around the trusting reporting to improve trust in the staff survey results for the last year. And there are 7 people presenting in all of those, and we've had a 5% increase in the numbers of staff that participated and told us their views on things in the organisation. It is a testament to, I think, the authentic commitment of the executive board to improve working arrangements for all of our staff. And there is more to do. It's a continuing journey that doesn't necessarily stand still. We have embedded in the organisation the cascade of those results down to service level and supported that work for them locally. In terms of the things that we've got, I think to celebrate, there are a couple of areas. The learning and flexibility, where we've moved learning, whether it's self-learning, team learning, and I think that's reflected from other things in quality and safety and what we're seeing from the other reports presented today. And the other element was we work flexibly. We've come a long way in enabling flexibility for quite a lot of our frontline staff and also support services as well. And that's going to need to continue as AI changes how we work and how we work much more flexibly, probably in the next 2 to 3 years. There are still improvements needed, and the voice that counts is very key. And we need to really focus within that on race discrimination in the organisation. And we're beginning to have much bolder, courageous conversations. And we'll have a programme of work over the next 2 years to really support our managers and staff to continue to speak up, raise their voices and practice approach. And that we're safe and healthy. We do have really good reporting systems. We do have to close the loop on how we follow up and tell people what we've done and what's improved as a result. These are underpinned in our values as well. And the focus for this year does need to continue that voice that counts to board to give you a further overview. And I'm going to pause there because I'm really happy to take questions. I know this is an area everybody's passionate about.
Thank you, Amanda. Questions? Diana?
Thank you for that report, Amanda. I think one of the sort of key concerns the committee notices and concerned about is, in terms of the staff survey, is the issue about racial discrimination. In particular, we know that these numbers are rising, and what I want to be assured about really is the fact that we are really tackling it, that we've got a handle on it. There's an issue about, we know, I want to hear from you how you feel we are going to tackle that. In some senses, I would quite like to have more regular updates about understanding how we're going to tackle this, so we can really break it down. You did mention the fact that with the steering group, which we've recently set up and which I will be sort of chairing from June, that we are going to dive deep into some of these key issues and really be able to tackle this and make it much more robust. But my key concern really is about the capacity and capability, the fact that we have an absence really of true.
Thank you. Great questions. And I think you're right, the assurance and the DPIs will come through the EDI steering group. We have started several programmes where we've trialled them, and we need to bring that framework back across all the actions where we're going to focus and invest in. So the courageous conversations around being able to handle it, they know how to call it out and address it, and they know how to support people experiencing it, are the strategic elements we've got to embed. And some of that it's there, but it's not visible enough. So we have e-learning, for example. The Leadership Live last week, we had a high impact session of discussing this in the room with over 100 senior leaders and asking some really tough questions of ourselves around what are we doing about this and what other support do we need. And for me, it's joining up our freedom to speak up, it's joining up our policies, it's about people being able to have the conversation they don't want to have, because that's the conversation that will change the culture and move this on. But also it's about publishing our results where things do become formal and we address it. We have exited people from the organisation where race discrimination has been found, and we need to share those figures more to give that confidence leadership team people and the executive. I think you're right, resourcing is always a challenge, but for me it's how we embed it for this to be everybody's duty, not just seen as a HR or people element. I hope that helps.
And I definitely agree that it is everybody's responsibility. But when we look at as an example on the quality impact assessments, that training is highly theoretical. I know we are introducing more practical training, but we're only just doing that right now. And there are lots of things happening within the trust where actually we need to be much more robust about having real operational training in place to support people to be able to deliver on these things.
Yeah, I agree.
Nina.
So just kind of, I'm going to ask the same question I didn't perform particularly well on this indicator last year. I remember Tom having also the same discussion. So my question is really, Amanda, how are we going to measure whether we've been successful? So when we're doing this next year, even if we haven't significantly improved, how are we going to measure within the trust that that those conversations are happening and that people feel comfortable. I'm just wondering how we're going to measure whether the steering committee, all of those things have been successful.
Yeah, so for me, I think staff stories are really powerful. We have used those at People Committee before, and we may want to bring some of those experiences to board, so you have some of that level of assurance. The staff survey does measure it really well. So I predicted 2 years ago that we would see the number of incidents of psychological safety, and that's what we're seeing. I imagine this area may say. The measures for me are the confidence factor of when I speak up, I have confidence that the organisation will address the concern, and that's within the staff survey. I would speak well of this organisation and advocate for this organisation is another key measure. And also, the other bit for me is managers' confidence levels and capability levels. And there are some easy measures we can put in when we roll out teaching to have a conversation and you're not equipped. Your capability might not be there. So where are they then in a year's time? So I think we can do those things really easily. But it's a combination of those measures, not just one of those things.
Yeah, right. So we've got a few problems. On that point, I just wanted to add something. I mean, I think another measure, and you mentioned speaking up, I think one of the really clear, for me, that I feel take a lot of comfort from, because I was talking to Freedom Speak Up Guardian only a couple of days ago. Yes, the number of concerns raised has gone up, and that is a good thing. What's even better is 0 are anonymous. And that, for me, is the most powerful thing, because the numbers going up, but the culture is improving. But absolutely recognise all and share the concerns. Right, I've got Richard, I've got Karen, I've got Tijafara, I've got lots. Okay, we'll come to this in a minute. Richard first.
All right. How many questions? So first of all, congratulations. I think it's great to see all the improvements in response rate and I think the best NHS organisation is about 70%. And I'd say in the commercial market, 70-80% is a really good response rate. So I think there's still work to do there. And people do this because they believe there's going to be consequences of what they say. So it's really important, and my question to you is, how are we going to make sure that all these action plans have the right quality? Final question is, I think the discrimination is a big issue. It's an important. We don't try to kind of solve the world, but be more specific in our target actions.
Yes, is the short answer to all of those things. So the local actions are there, and we have the hotspots, and we have a healthy culture programme. So the people team and the partners triangulate this data amongst other things like turnover, absence, and we'll roll those programmes out in those areas where we know they need support. The local action plans will come back to the EDI steering group, and each division comes on a cycle of presenting all of their EDI data, but also the actions they're doing. So the accountability will be in that steering group. And then at the People Committee, there's a regular quarterly update or biannual update to that committee stage. Average is 67% is probably the highest within, and I think we can continue to increase that. Do I think we could go from 50 to 70? Not realistic. Do I think we can continue to do 3 to 5% year on year? Yes, I do. And I think that is achievable with the collective effort that I do see from execs and from senior leaders now in the organisation. And that's part of the positive cultureship, I think, in the trust that we have. I think I've got most of it.
Yes.
I was just wondering, so I think it was about 12 months ago we had a video which I thought was excellent, that was Civility Saves Lives, and I'm watching that and thinking this is really good and really powerful and actually really simple, and it came from the ground upwards. What do we do to really make sure we embed that type of thinking? Because that seems to me just something everybody can understand, and the impact of it has been felt to be enormous. Are we doing that area?
So Civility Saves Lives is it features in induction and it's flagged, and staff do look at that in induction. And through the primary service and the medical director's office, there is a programme of Civility Saves Lives. So where we identify hotspots, it's one of the first modules we run with those teams, and it is readily available on our intranet and on our Learning Academy for staff. I use some slightly different videos at Leadership Live that are quite impactful as well. So for me, it's curating those resources in one place to make them easily accessible. But Civility Saves Lives, there is a version 2, we're beginning to map that out, and we'll look to how we fund that, because there's some follow-up of those people that initially featured in the video to show what their journey is like now, and that can be just as powerful.
Right, there were three down there. Let's go through them quickly. So I think Justin was first, then Teresa. Thank you.
Thank you. I want to talk about something really difficult. On page 50 of the pack, you can see some questions 16A and 16B, and these relate to racial discrimination. So we've made some improvement, but not enough, on relationships between manager and staff around racial discrimination. But the other group that's made staff, and I think that this is a really important area in the NHS. I think it's an area that we need to give some focus to as a board, because we need to support our staff really strongly when there is discriminatory thought in both of them. We need to make progress on. I'm sorry, that's more of a statement than a question.
But I think we would all agree with that. Thank you, Justin. Teresa.
Just to highlight a bit of what custodian bionic at the moment, but I'll do if you're a guardian reader, if you want to read about New Kindness campaign, and it really focuses on patients, and it focuses on respectful conversation in Croydon, but supported by nurses to the mum, just to understand what because Civility Saves Lives is a great campaign, but what practically people do with their patients and what was their learning. So anybody that wants to join us, and I know Dana's interested, maybe Jill is very welcome to join us on that full official plan, because it is everybody's responsibility.
Right, thank you very much. I'd like to bring this one to a close. Richard May. I think we need to be much smarter at spotting where the hotspots of poor behaviour are. And I know with Tom, before he left us, I had been talking to him about creating a culture heat map. I know for various reasons we weren't able to do that. Be able to drill down, and by the way, what I mean by a heat map is a culture, but it marries it with hard data like vacancy rates and mandatory training, compliance and appraisal, and really pulls the things together. And it's something that my plea is there. On the other points, however, just to bring this to a close, this paper was marked as a substantial assurance, and I have to say I'm very concerned about that. I mean, to me, there is absolutely progress here, and I completely applaud, as others have done, that we've made some really good progress, and being the fourth most improved is great. The bottom line is we still only have participation of 1%, we still only are in the middle of the pack, and we're saying that of our discrimination, 2/3 of our staff are on the basis of race, and I find from substantial down to reasonable. There is possibly an argument for going even lower.
Could I just ask, is the assurance on that we have the information on that we're achieving the standards?
It's on the issue, not the paper.
As long as the paper gives you assurance, it might well be that the documented evidence is here. It might well be it's substantial assurance, so you've got all the information, but...
I really want us to move on here. Jill.
Can I just say I completely agree with your summary of that. The issues that have been raised by colleagues around, I think for the definition of reasonable assurance, what fits there is that issues have been identified that need yet to be addressed. And I think because of the dialogue we've had, I would completely support your suggestion that reasonable assurance.
I agree.
Agreed? Great. Thank you. Let's please have that minuted. But thank you very much. As I say, some good... Right. Time is pressing. Our next item is the digital strategy. What's the time? 11. Okay. 15 minutes. Are we okay to... That would be brilliant. Mark, this is not... It would be...
Thank you. So this represents the 5-year strategy from 2020, and to a certain extent is a wrap-up of is that the strategy was formed coming out of COVID. So it was basically formed on a basis that we didn't really have an EPR. We had two kind of partial EPRs, but during COVID we realised that we needed digital systems. So we leverage a huge amount of value. Nurses using assessments, etc. all came from that kind of drive through COVID. We also, during that period, and very pertinent for the patient story early, is that we connected our systems to the Hearts and West Essex Shared Care Record. And as I said earlier, is that anything that we create digitally gets fed through to that record and is available to all providers, primary care, community, mental health within Hearts and West Essex. EPR, we had to implement some specialty systems, so replacement for ophthalmology, for audiology, for gastro, very successful deployment within maternity last year, and still really embedding that system in and going through some of the optimisation around that. We also saw a move away from devices. Every single doctor in the trust has got a mobile device, and nurses have got a shared device. Moving on to the technology platforms themselves over the years, the focus is always around EPR and forgetting that the PCs need updating and the infrastructure. So over the period, we've replaced every single one of our PCs. There's no PCs that are more than 4 years old at the moment. They all regime on them for cyber security as well. So we've got a well-managed enterprise of PCs, and of course, as we've seen over the period, is that M365 MS Teams has just become a standard business tool. We don't even think about it, but you go back 5 years ago, it was a new concept to ourselves. Also, we've focused around resilience, and many of our critical systems now sit within. We haven't adopted this process of throwing everything out and going to the cloud, but where there's been a new big focus as well. We've built a cyber team over the years, so we have got our own cyber team on site. We are fully embedded into NHSE's Cyber Operations Centre, their SOC, and we've been a strong advocate of it. We were the first trust to have every single one of our accounts going through multi-factor authentication. And if you think it's a pain every time you log on, getting text and logging in, but it is essential, and we've been championing that. And I think finally that we started our EPR journey, believe it or not, back in 2022. We went through various processes with NHS England around strategy. We went through a process of did we need the same EPR across the ICS, which looking back now, maybe that probably wasn't necessary anyway. And lots of bids for funding, which in the main didn't come to anything. So February 2024, so last year, is that this board signed off a self-funded EPR programme, and we signed a 10-year deal with Dedalus for their August product. The programme fundamentally funded a cost pressure years 1 and 2 with an aggressive business case benefits case in year 3 to fund it for the rest of the period. So whistle stop tour really around what we've delivered in the last 5 years and where we're going. Up until the end of this year now is that we're now to recut the new 5-year strategy and then bring that to this board at an appropriate point, tail end of this year, beginning of next year. Happy to take any questions.
Brilliant, thank you for that great summary. Questions or comments, please, Jill?
Two quick ones, if I may, about the EPR future terms of reference.
Oh, sorry, we haven't got to that paper just yet, so that's the next item. Okay, but yeah, we'll do that. Right, Teacher Farah.
Does this new one EPR system does it mitigate for challenges that we saw? Because I know we talked about the shared records being part of it.
Sorry, could you speak up a little bit, Tisha? We can't hear at this end of the table. Sorry, thank you.
No problem. So my question relates to the one EPR system, whether it's going to help us address the challenges that were raised in the patient story for starters. And key or the most important part of that question relates to what Justin raised around the difficulty in getting access to that shared record. Is that something that we foresee being actually addressed in the system?
Absolutely, and without being too technical, we've got 2 EPRs, one that manages the patient administration and one that manages the clinical flow. The shared care record is embedded into the administration system, which isn't used all of the time by clinicians, so it's an in-context view. So when I look at patients up, it will tell me there are other records within Hearts and West Essex, so I want to see them. However, the system that is mainly used by the clinicians doesn't do that. There isn't the integration, so it means that clinicians have got to move away from their system and go to another system, and therefore taking more time. So there is the process is not very smooth because of the way we've got them configured. With one EPR, it is what it says on the tin. It is a single system, so therefore that's a long answer to say yes, it will fix it.
Great, Richard.
Yeah, so we did discuss this in FPPC, so we recommended for approval. I think we really support the content of the paper with the remark that Mark made at the end, that we need to do a piece of work end of the year to look forward. I think also to say that also based on some of the other experiences I've got, I think some great progress has been made here. So having all of the things in place in terms of the IT for the rollout of one EPR, so really good.
Thank you, and thank you for that endorsement. Great. Okay, it was for discussion, so we don't have to take any decisions on it. I thought that was a good update. I welcome the commitment for us to look at our digital strategy going forward towards the end of the year. Let's focus on what we have to do now, but I think it'd be right or what our aspirations are. So I think that would be great. So thank you very much. Right, I am going to call a break, but just before I do that, because I think this is hopefully a straightforward item, the next item is approval of the terms of reference of the One EPR committee. I promise, and I note that Jill had one.
Sorry,
so
just ahead of myself there. Just two quick ones really. It clearly says in the terms of reference, to ensure effective governance and risk mitigation. And I just wondered if we could have confirmation that that would specifically include seeking issue done and acted upon as part of that process. And the second question was just if a decision had been made yet with regard to the NED membership.
Richard will be chairing it, David will be representing a clinical voice, and Janet will be representing the staff voice. There's just some three. That's what I've tried to go for. Right, in terms of the first question, comments?
So, yes, absolutely.
Yes, definitely. It just wasn't explicit in the wording, and I just thought it would be helpful to be explicit. That's great.
Are we comfortable making that change?
Inaccuracy. We haven't met in shadow form yet. The paper says it, but we haven't. So just.
Thank you. Okay, if we could change that then. Lovely. All right. Sorry. Oh, sorry, Nina. I didn't spot. Sorry, apologies.
I know it's hard to see everybody around
yes,
the
yes.
table. Just for the BAF, not really done this and then came for. So would that be included in that risk? Because I'm just thinking that is obviously a risk for us as well, because we're having to create something with them in partnership. So there might be a little bit of delay on their side. So do we need to capture that somewhere?
With the strategy, for any reason, whether that's staff engagement, whether that's non-delivery of the product, it's not explicit in it, but then there is a large risk register that's associated with the project, which absolutely has that risk in it.
Thank you.
Okay, thank you. So, subject to that change of wording and, as I say, the slight correction to the covering paper, are we comfortable approving these terms of reference, please? Yep, thank you very much. Right, I will like to call a 10-minute break, please. And therefore Welcome back. We're now moving to the next part of our agenda, which is integrated performance support, which we're actually going to go through and see how that pans out for yourselves. Let me hand over to Martin.
Okay. Well, I expect the trust on there, and as Mia said, we're going to try and do a little bit of a different format this year, this month, and maybe that's slightly reflective of the fact that the IPR of the integrated performance document that we're looking at is represents the full year for 24-25. So I think it's a little bit about trying to tell the story of the journey to our kind of core kind of domains and picking out some of the key headlines and messages from that, and then probably at the end of that I'll turn it over to kind of committee chairs for any aspects that they want to add on there. So I think 24-25 has been a significant kind of year for the Trust in terms of its performance, because certainly against the backdrop of what has been significant operational and financial constraint, I think we have posted some significant kind of improvements, areas that we need to kind of improve. But I think if we step back and look at the bigger picture, there's a story, a positive story to tell there. So in terms of kind of the quality, some really important sustained improvements. So if we look at our crude mortality, HSMR and SHIMIs, our measures of mortality, all are improving and are now within the top quartile kind of nationally performance there. And I think that's really, really important. We have 96% of safety measures where the result of 96% of safety incidents have resulted in no or low harm. We have daily incident hurdles that have been implemented, and that learning has been shared and embedded within the organisation. We have across sepsis care, we have improved the timely antibiotic administration in ED and patient areas, and then training and equipment rollout driving success. So I think that's really important. We know there's further work that we need to do, however, in terms of kind of thresholds and VTE compliance, and that remains an active area of monitoring for us. And similarly, the IPC picture is still a little mixed as well, across MRSA and MSSA as well. Complaints increased late in Q4, but that's, I think, largely due to outpatient follow-up kind of delays in there as well. And then across kind of maternity, that's an important area for us. Maternity safety generally pretty stable position in that area as well. So there may be some key features to kind of call out in terms of kind of quality of care. I think within our operation there are a number of kind of dimensions there. In respect of cancer, all three of the key national standards met year to date across the year. And the Trust is in the top 10 in terms of 62-day. Months of improvement, best in the region for under 18 weeks waits, and a stable 52 breach kind of position in there. Yes, of course, challenges in terms of managing individual specialties, but I hope you probably will see significant progress. Community paediatrics, however, does remain a significant challenge kind of for us, and something that we will need to continue to work on in the months and probably years to come, particularly with system colleagues as we look to improve performance in that area. ED performance, I think again we can see significant kind of improvements, particularly in the last quarter, 73.8% kind of 4-hour performance in March, and I think that performance trajectory is continuing into April, and I think even May looks pretty strong kind of at the moment as well in there. Stroke stay kind of reducing. We know that in terms of thrombolysis and 4-hour access, that is areas that we need to kind of maintain improvement sort of on there, but still, I think significant success, and we can see that within our kind of SNAP and below target and audiology, and particularly kind of MRI in particular kind of focuses for that, and we have set out very specific plans in the year ahead in terms of how we're going to kind of improve that. Moving on to kind of financial performance, and obviously an area of priority for me as the finance director. I think as Adam kind of highlighted a little bit earlier on in the CEO's report, on there, as we get to the end of the financial year, a £1.5 million kind of surplus kind of achieved for the organisation, kind of marginally kind of ahead of plan, but certainly good performance when compared at a regional and a national. Some of the ways that we've achieved that have been reliant on non-recurrent kind of solutions, and we need to kind of address that kind of moving forward into 25, kind of 26. Our elective income, while good, was slightly kind of below plan, and we do need, going into the new year, to continue our kind of focus on throughput and kind of productivity. And we have had a range of kind of hotspot issues that we've needed to deal with kind of during the year, and the board members will recognise these. Renal, pathology, maternity are areas that have kind of featured in there. But I think again we have done good work kind of recently getting to our grips on those run rate hotspot kind of areas, and certainly we can see improvements in terms of performance going into now, and I'd hope that in June that audit process will complete, and the audit committee will kind of look after kind of approval for us. Areas where we are able to evidence kind of strong progress around recruitment, strong progress around kind of agency and temporary staffing control and reduction in the years that we've been through. Our vacancy rate is 8%, and that is the best that it has been for a significant kind of number of years on there. We've seen our workforce kind of strengthen, particularly within kind of nursing. The fill rate in terms of substantive, which is really different compared with many other organisations kind of locally. Statman and appraisal rates are below the targets that we've set, but still a significant improvement on kind of previous kind of years on there. But I think we've already just had a conversation of focus that we need to work on kind of going forward. So I think a very challenging environment for the NHS across a whole range of kind of performance measures on there. But I think, you know, as I step back and look at the trust performance across the range, I think there are trust can evidence kind of from its delivery kind of this year. But of course, to supplement our performance kind of environment going into 25-26 with new work around our accountability kind of framework. And that's not just to create governance for the sake of it, but that is to drive kind of better and improved performance across the organisation. So I'll stop there, Chair, but I'll maybe hand over to committee chairs in terms of further thoughts and reflections that they might have.
Thank you. To take that on. So yes, my suggestion is that we hear from each of the committee chairs initially, and then we'll open it.
Thank you.
David. So there you go.
Thank you very much. A couple of things. Thank you, Martin. I'd like to clarify whether we have any clinical concerns around blood clots or unnecessary blood clots, VTE and HAT. Our risk assessment has gone down, and we know there's a mechanical explanation for that, an administrative explanation for that. But is there a clinical change here? Is there a clinical concern?
Yeah, come to me.
I can't go.
So I am worried about this. We're not getting this completely right. So you're right that the number went down dramatically because we changed the way that we measured this. We were measuring it as 14 hours after the arrival on the ward, and actually what we're now doing is measuring it as 14 hours after arrival in hospital, which is the correct way to do this. We are seeing small numbers of patients getting clots, some of which may be unnecessary, and that's something that really upsets me as medical director. So we're looking at a number of process changes to try and improve this. One of the things that we're talking about as an organisation, and we haven't done yet, but I think where we're going to end up on this, is that no patient needs ED without a VTE assessment and without thrombolysis prescribed, if that's what should happen. That's probably where this goes, because we've been looking to see where can we put the barrier to progression in clinical pathway without this being done, and I think that's probably going to be the most practical way to do this, but that's something that I'm talking to all of the teams in the hospital about at the moment, because we realise that this is an area that we need to improve.
Thank you. Chair, I raised it simply because, you know, often we can treat blood clots quite effectively, but sometimes if you have a large blood clot or repeated blood clots, actually I've seen people, patients really adversely affected. If I may ask a second question, which actually features in my alert of my escalation report. So I've noted a couple of things, and they may or may not be related. So complaints are on the increase. PALS service is very busy. We heard earlier on about we haven't got an EPR yet. the reason I'm asking this question is that I understand that our operative cancellation rate at 1 week is 30%, and we have 20,000 patients going through the system a year. So we are cancelling a lot of operations. And some of those people are coming back through PALS and through complaints, I believe. So I wonder if there is, something more that can be done or not.
Do you want me to come back on that? A lot of that would be rescheduling of patients within a very short time frame to either sort out the list order or to make way for more urgent patients or cancer patients. I would need to go and do a deeper dive to see if that rate is increasing in a way that is of particular concern to us. I don't recognise the figure that you said, but that doesn't mean it's not true. So,
it was taken from a GIRF report at 1 week preoperative, and I don't know the cause or the explanation to sit high.
And we know that we're working hard to improve our preoperative assessment processes, and a number of those cancellations will be as a result of preoperative assessment rather later in the pathway than is ideal, but discovering or finding a preoperative assessment that there's a problem that needs addressing before it's safe to operate, which means cancel from the plan that they had, put something in place to ensure they're fit to come back for surgery. But we'll go away and do a deeper look at that.
Thank you.
Findings.
I think Justin wants to come in.
Really just to add to what Lucy is exactly right. Because we have long waiting lists, and we have long waiting lists across the NHS, it compared to when they originally discussed having their procedure. It's that preoperative assessment that's leading to changes a week out, because that's when we're seeing patients and realising that they're no longer fit, or that we need to do other investigations before their surgery takes place. As we bring our waiting times down, procedure, and therefore we won't see that clinical change.
Okay, right. I'm conscious of time. Kevin wants to come in, and maybe we'll just have, if there is anyone who's got a question, particularly on quality, we'll do that, and we'll move to the next section. Kevin.
I'll be brief, just building on the picture from Lucy and Justin. The teams have introduced a text reminding service in the last couple of months that's seen significant improvement and reduction in cancellation rates over the last couple of months. So that's one area of work that I definitely acknowledge. I'd also reflect that the team introduced a health questionnaire electronic form sometime last year on the basis of the NHSE peer review visit, which means that there's a much more robust process for assessing patients that are coming on to the ratings moving forward that will also address a lot of the shortfalls that you're referring to, David. There's lots of work that has been undertaken and is ongoing at the moment as we speak in terms of the value stream development for pain around process improvement. And I guess the fourth element then just to say is that there are bits we're interested in, but obviously this is just something that requires further risk assessment conversations because it goes against our one EPR principle, and there would be other caveats that I think put in place with that in terms of financing and resourcing. So I think there is a lot of improvement work that is underway that we can address, but obviously where we need to be.
Okay, right. I'll take one comment on this.
Yeah, so just very briefly, I'm going to bring Mark in because I think one of the areas we have seen a fair bit of PALS activity is where people have been unable to get through to us. So they've been ringing, trying to get through the contact centre to cancel an appointment themselves or to check up on something. They can't get through, then they may get a discharge note to say you've not turned off your appointment. But some actually pretty outstanding work that's happened in contact centre, which do you want to give us one minute version of the change? Because I think it's quite significant.
Yeah, so as you to ring off, we're very, very high. Since January, we've rebuilt the contact centre, not just from a technology perspective, but retrained the staff and put new processes in place. And we're migrating our services into the new contact centre. So currently we're about 65% of our services now sit in that contact centre, and our abandonment rate, which was in the high 60s in January, is now sub 4%. in a new contact centre. In fact, one day in May, 1st of May, we had 0% every single patient that called the contact centre was answered. So by the end of June, every single one of our patient lines will be, or outpatients will be transferred to that contact centre, and we will have a sub 5% target for abandonment.
Yeah, which is fantastic and a great achievement. Right, if there are no other comments on quality, I'm going to move to Richard to talk about ops and finance, please.
Thanks. I think the report kind of highlights the right things. So yes, some really good consistent improvement in operational performance in a number of areas. Our biggest concerns are diagnostics, MRI and audiology. It was really good to hear some of the audiology plans, because we've been waiting for them for quite a while. And I think on the UEC metrics for our 12-hour waits, that is really the last quarter we've seen improvement. So we really look for, let's say, the sustainability in those things. I think on the financial side of things, great, we've been able to deliver on the goals that we have agreed with the system. I think our concern is around the exit run rates, because we didn't do everything we said we would do, and as a result we didn't end the year exactly at the point we were planning for, which puts a higher pressure on the plans for this year, which when you look at the CIP plans, they are still relatively immature, so that needs to be a real area of focus for us going forward. And I think the final thing I mentioned, which is not in the report, we talked earlier in the meeting about the collaboration with the HCT effectively. This is going to eat quite a bit of energy from the executive team and also from the non-execs, the board. And there's a risk of getting our eye off the ball when it comes down to operational financial performance. So this is something to really watch.
Yeah, thank you, Ole. Any questions or comments on either the areas or Richard's comments? No? Okay, thank you very much. I think many of us have had those conversations, Richard, about your last point. I think we recognise how stretched the executive team in particular are going to be in the next few months, and I think there is a danger that our bandwidth is insufficient for the challenge we face. But okay, thank you very much. Janet, our Chair of People and Culture, is not here, so I'm going to ask Diana to comment.
Yeah. I think in terms of the performance highlights, I summarised some of the really good progress that has been made. I think with Janet, the key things that she really wanted to emphasise, and we've talked a little bit about that already, was in relation to the staff survey and issues around discrimination, which we've talked about. I think the one other thing there is really about the way in which the committee runs itself, and we are trying to really tighten things up in relation to how it operates. With the new EDI steering group, there are things that we are moving away from, with the people and culture, and moving that into the steering group so that we can go into a lot more depth, so there will be tightness, there will be much more robustness, and we'll focus on with the people and culture in terms of getting assurances and being much more strategic in how that operates.
Great, thank you. Any questions or comments on the people report or indeed Diana's report? No? Okay.
Yeah, could I just make an overall comment of reflecting around the IPR, but also more generally, because I think we've got some real points of tension arising. Richard just drew one of those out in terms of when we're being drawn more and more, particularly as a chief exec, to spend time and energy externally. It's getting that balance right. But even in this meeting, we've spoken about can we build some more training here? Can we strengthen that leadership there? Can we do that? We're at a time when we're basically saying we've got to take 1 in 20 people out. It won't be 1 in 20 people because we know we're really focusing on non-paid and temporary staffing. But when you've got a 5% cost improvement plan, that's not insignificant, as Richard highlighted. And anything, therefore, we want to put our investment into just increases that number. But I think it's also, there was a comment in the IPR, I think in the people section, talking about things like StatMan training and other development bits of work. What we have to understand is there's an awful lot of people who are putting their energy at the moment into the cost improvement work and aren't doing the day job. So I think there are some real tensions that we're going to have to be monitoring frankly, knowing what are the areas we are going to have to let slip. And in the previous session, I remember Jill highlighting very helpfully as a non-executive to the execs, what are the areas we knowingly will have to put on the back burner, because otherwise we're going to do lots of things badly. And I think so it's going to be important that we're very sighted on it as a board. We flag the risks because we are trying to get lots out of, say, people who don't mean exec level, but our teams are being targeted, so we're going to have to be mindful of that.
And do we have clarity about what are the things that we think we are going to have to let slip?
Probably not sufficient, because I think at local level people will do, but there is that, I think the general thing at the moment, people are trying to do everything and trying to stay afloat. And I think we are going to have to be better at saying, we understand this is what we would want to do, but this is something that will just have to be parked. We do, though, genuinely believe that even in driving our productivity programme, and we're still seeing really good examples of this, there are areas where we can take money out and improve the working experience for people and improve the operational performance. And we've just got to go at those. But I do think there are some areas where we're going to make some difficult decisions and have to say, yes, we'd love to do that, but we're just not going to be able to do it, because there is, if we invest in that, we're going to have to take even more.
So I think, and I know David's waiting, and I'll come to you soon. And I think just to finish this bit, I think that makes absolute sense. I think what my plea would be from the board is that as and when you have that clarity about what those things are going to be, please can we have a conversation about those, because I think we will get it. We hope that there are going to be productivity savings that will mitigate some of those reductions in headcount, but it is almost inevitable that bandwidth is going to struggle, and we need to be clear, and we need to, as a board, agree that the right things are, if you like, are being deprioritised. So my plea would be, please let's have that conversation as soon as we're ready to have it. David, you wanted to come in?
It was very much on that theme, and I was going to just thank Adam for clearly stating the position, and yourself, Anita. So we have a real problem with preoperative assessment, which needs to be resolved. However, I understand that we can't fight every fire. We have to choose what we can do, and we've got to take into account the bigger mission, which is around One UPR. So I raise clinical concerns, not to bash the board over the head or bash the executives, those risks.
No, agreed. And I think I think we all of us are totally focused on making this the best organisation it can be. We know that is our goal, and I think that means that we are all striving to do better in all areas.
I think in the past, when we've raised concerns, there's been a sort of, well, we'll fix that, and we may or may not be up against the buffers occasionally.
No, agreed. But I think, therefore, it is about tough decisions, tough choices, tough prioritisations, that the sooner we are clear, and we can be clear to our staff as well, because they need to know what are the things that we are going to be prioritising or not prioritising in the circumstance we find ourselves.
And just to come back briefly on that, because I would say that for me that's the bigger issue. There's the big strategic things we might say we won't prioritise, but it's that middle manager who is under pressure to deliver their SIPs, to make sure all their staff have had their appraisal, to do the other
mandatory training, etc.
And I think we need to give them that. It's our job as senior leaders to give them as much steer and help in prioritising, rather than leaving them to work it out themselves.
I guess I also just want to be clear to leaders, clinical leaders in particular, about we really agree with you, but at the moment,
agreed. I think we're all in agreement. I think it's just about getting that clarity and communicating it, which I think would be my ask. Okay, in terms of the integrated performance report, does anyone have any further comments or questions? I'm not seeing any more hands.
No.
So I will say no. So thank you very much, everyone, for that conversation. And as I say, overall, I would agree with Martin's assessment. Actually, we have a lot to be proud of in that year. I think actually there's a lot of progress been made in all sorts of, probably on all domains, actually. Yes, we have more to do, and and we wouldn't be the organisation we were if we didn't think about those things and focus on those things. But actually, we've got a lot to be proud of. So yes, well done everyone that's been involved in all aspects of our operations. Right, moving on then. There was a paper here about the BAF. I don't know, Debbie, if we can take it as read. Are you happy to take it as read?
I am happy to take it as read.
And just go for questions. So just before I come to you, Karen. So this, was it last month, where we talked about rewording the BAF. Stuart then went out via email and was gathering various thoughts from various people. Summary of everyone's comments. We do still have, is it 12? Or, yeah, we're down 11 now. It's gone down to 11. But in terms of what we consider the highest risk, and that was as a result of, well, I don't know where that's come from, but there may be some things that perhaps haven't come up and landed in quite the way we intended. So I'm going to open it up for.
Thank you. Apologies, I was so quick off the mark there.
We like enthusiasm, it's all right.
I just had 2 points really. The first is on the one that is a brand new risk, which is to do with change, and it's just reflecting upon the meeting that we've just had. And that is, I think we need to build into it as well about needing to keep our eye on business as usual, as well as our wanting to improve and adapt. I think it's reflecting where we are in the course of this year, but otherwise I'm really happy with all of the risks as framed, but I would adapt that one. The other thing when I looked through it is I was struck by the fact that the risk oversight was predominantly at FPPC and people and culture, and there was only one risk, the quality and safety. And I just felt that the focus on that to me appeared to be maybe slightly distorted. And so I know it's not the framing of the risk, but it's the committee that's going to have responsibility for oversight. And I just think we maybe need to take that one away. I don't think we can discuss it now, but I do think more of this is actually for quality and safety to oversight on.
Yeah, I think that is a good point. I mean, I think it's a consequence of the things we're most worried about, if you know what I mean.
Yeah.
But that does. But I think your point is well made about the workload for the different committees. And clearly, there is also that thing about actually an awful lot of these things we might be framing them in terms of, well, this is an FPPC thing or a people and culture thing. But in reality, it always comes back to patients,
yes.
And therefore there is something about rebalancing of the assignment to the committee. I agree with you. Thank you for that point. Richard.
So I completely agree with what was just said by Karen, but 2 things. I think it is a really good reflection of our conversation and of the current situation. One suggestion I've got in addition is that the digital transformation risk is on FPPC. My question was, should we now put it on the new EPR committee?
Number 10. The only reason I slightly hesitate is that one is a specific task and finish committee that is only of temporary existence, we hope. I mean, that may be a couple of years, but it probably is going to be temporary. Do we think it needs to be one of the standing committees, or would we be happy moving that one to one EPR? How do people feel about it? How do you feel about it?
Well, I think I wouldn't object on that basis. It's more about, I guess, from Mark, because this is broader digital than the specific, but as one APR is such a driver, it might be. I'm kind of a bit agnostic about it.
Mark, what's your?
That risk is purely related to one EPR and outpatient transformation, so I would be supportive of moving it to the one EPR route.
Okay. So if no one has any objections, can we make that? Oh, Karen.
It's not an objection, but what I'm saying is on just to make sure that we're not missing anything, that there's no risks that fall through this. But I agree with Mark, because this predominantly is about outpatients and our one EPR, so I think it should work.
I'm very happy for audit risk, and have a look at all of them if you want.
I will do.
I'm sure you will. So that's fine. But no, I think that makes sense, absolutely. Right, any other comments on the BAF Obviously, this is a living document. We will update it as and when we need to. But where we are today, are we happy? Great. Thank you very much. We'll take that as approved. Thank you very much. Right, I'm going to, the next item is the ICS performance report. It's historic, the data is 2 months old. I can't particularly see that it's got anything particularly exciting, but we note the paper. If someone has got any particular questions or comments, feel free to raise them now, but my proposal would be that we just take it as, that we just note the report. Yep. Okay. Thank you very much. Moving swiftly on then. Sorry.
I don't disagree at all. I think it's here for information, nothing more. I think where we're going to see the transition now as the reporting HCP levels, I think increasingly that will come back here with some real more, and actually importantly, because we will be assuming responsibility for that delivery.
No, completely agree, and that's in my head too. That actually this stuff, once we're a host provider, we're actually going to have to care about everything in our place, not just acute metrics. So yeah, completely agree. Brilliant. Okay, thank you. Moving on then to mortality.
It's always difficult because behind each step there is a family who are grieving, and therefore I want to couch the terms I use carefully. However, when I look at the data, what I'm seeing is an organisation that is doing what it needs to do, that's providing good quality care, that has mortality indicators that are all heading in the right direction, and where there are points that are raised through the HSMR or the SHMI, that we understand those points and we know what we're doing about them. So I would like to suggest that this report offers assurance to the board. I'm really happy to take questions on it. You'll see that we've put it as reasonable assurance. The rationale for that was that we had some difficulty with data feeds over the last couple of months. And what you'll see is that the data in month changes as we move forward by a month. I think once we've got that rectified on a permanent basis, we can be really certain that not only the historic data we're seeing, but...
Thank you, Justin. Questions, comments? Karen.
Sorry, it gets towards the end of the meeting and I wake up. So, it's just, I'm slightly confused because there's a table on structured judgment reviews, and at the bottom it says Mount Vernon cancer deaths are excluded. As these deaths are not scrutinised by our ovarian cancer. So obviously we do get some information through. But if they're scrutinised by Hillingdon, how do we get the...
In reality, and thankfully very few very unwell patients as inpatients at Mount Vernon because of all the things that we've spoken about in great detail. We do have morbidity and mortality meetings for each of our cancer subtypes at Mount Vernon, and those meetings are taking place. So we are analysed external SAC mortality, and that's obviously what everybody remembers from the ovarian cancer. So there were a number of ways in which we analysed deaths through Mount Vernon, and actually probably what's more useful is to analyse the deaths of all of the patients going through cancer pathways that are run by Mount Vernon, rather than analysing deaths that take place in Mount Vernon. The two are very different, and it's the former rather than the latter that I would much rather look at.
And that's something that we do.
Excellent, thank you. Any other questions or comments on this report? No. So thank you, Justin. I think that, as you say, it's a you've suggested an assurance level of reasonable. I think there's some good data here that implies that is an appropriate level of assurance in my mind, but I'm very open to others' views on this. Do we want to go up? Do we want to go down? Are we happy with reasonable?
I normally feel it's excellent, but just to explain why
Okay.
I want a different schedule.
Yeah, I think the sort of slight
not dodgy, but slightly not sure about the data, means that we maybe have to be a little bit more careful. But I think that thank you for the report, very clear as always. Then moving on. Just missed the dashboard. Right, Audit and Risk Committee, Karen.
Just a couple of things I wanted to highlight. The first thing is just to ensure the board that we're keeping oversight of the side of the report at this moment, but we do have eyes on it. The other thing is just to say that we've asked the Audit Committee for some understanding of the way the pathology contract governance is working, and that is because it will begin to happen. But it's just really to make sure that we've got good oversight of that, and also to pick up on some of the issues that were identified at FBPC during the course of last year as well. So it was really just a note.
Thank you, Karen. Any questions or comments for Karen?
I've got one question. Karen knows the question already, which is we were going to audit our. So I was wondering when can we expect the results?
So I received a draft report from RSM yesterday. So management will respond to that. That will take place in the next couple of days. So the next meeting of the audit committee, that will come back.
Perfect.
Okay, thank you very much, Karen. So moving on, the next one is Remuneration Committee, some changes to the terms of reference, which I think most board members are aware of, where last year I proposed some changes, partly in recognition that the demand line and maybe a sort of schedule on an ad hoc basis rather than when we needed to, rather than sort of having it at a set time. I would hope that that the paper and the detail of the terms of reference are there and that you've read them. Are we comfortable with those changes? Do we need to make any changes to the changes? Open it up. Jill. Obviously,
this predates me, all the discussion, so apologies for that. I suppose if, for me, understanding that the details here say there'll be a chair and 3 NEDs, I suppose there's a question about which 3 NEDs, because that may be known, but I don't know that. And also just then what would be the intentions for ensuring that, say with regard to the responsibility for evaluating the performance of executives, a key function, what's the intention for other NEDs not on the committee to inform that process? And I also wondered about the quorum. Is in fact just 2 NEDs, and whether there was any reason why, given the reduction in NEDs, and there's only 4 NEDs, if decisions were to be made in that regard, all 4 NEDs would have to be present. And with just thoughts along those lines, as you'd obviously made the decision to reduce the number of NEDs, if I was an exec, I think I would prefer for all 4 NEDs to be part of that process if there was just
So let me try and answer just some of those questions. Yes, so the members are myself as chair, Karen as deputy chair, David as Sid, and Janet as chair of People and Culture Committee. So we are the 4 people. One of the reasons that our scheduling has become a little bit more fluid is actually to make sure that we can get everybody there.
Yes.
So that's one of the things that happens, is that whereas it used to be very much straight after board, given it's a smaller number, it's actually easier for us to schedule it at relatively short notice. So we have not yet had it. I think 1 NED has been missing, but we've had 3 out of 4, and that's always been a last minute issue. But we move it to try and ensure everybody will be there. Your other question, which I think is a good one, was about feedback into the appraisals of exec directors. I don't know, Adam, if you want to comment.
Well, I guess so it's not a role of the committee, but it's a useful challenge, Jill, which I'll take on board in terms of going forward when I'm doing the reviews, to see how I get a take from non-executive board colleagues, particularly around the board performance of those individuals.
Yes, I think at the moment I gather feedback from all of you and I feed it into Adam on the other executives. But whether we could strengthen that up and make it formalise it in some way, I think that's a perfectly good, sensible thing for us to do. And I should say it works the other way too. The Adam tends to gather feedback on the non-executives from the execs, and that I feed into appraisal. So it works very. So at the moment we're kind of the link with our respective teams. But should we be formalising that some way, that we should be asking the execs to give formal written feedback on all the non-execs? Yeah, maybe that's a possibility, and vice versa. But let's take away and think about how we want to do that. But I think it's a good question. Thank you.
The quality of two, what do you think?
We could make it. I agree. I didn't actually. Yeah, I think.
Just this two.
Yeah, I agree. I think it should be
for
three. Let's go three. Let's make it 3. I agree. Can we change that to 3? I agree. I actually hadn't noticed that, but because that wasn't one of the things I think we discussed. But that's fine. Yeah, let's make it 3. As I say, it's actually a lot easier to schedule it now because we're not trying to get 9 people together.
And probably just for the avoidance of doubt, in that bit, non-executives including the chair.
Of course.
Otherwise, someone might read it as the chair and 3 minutes.
Yeah, thank you. But yes, if we can make that change, Debbie, that'd be brilliant. Okay, subject then to that, and Adam and I will go away and consider a more formal route of getting feedback of all the non-execs on all the execs and all the execs on the non-execs. We will take that one away. Are we comfortable approving these terms of reference with that change of the quality? Yes. Thank you very much. Let's move on then. Next item was the annual cycle, which is as it was. Any other business? Has anyone got anything else they would like to raise at this time? No? Okay, thank you. The next meeting then is on Wednesday the 9th of July. It is online on that occasion. And with that, thank you very much to everyone for your contributions. A really good discussion as always. And I will see you all very soon. Thank you very much.